So thanks to my friend, I have a latest version of the first aid. And today we are going to do reproductive pathology. Let's start with sex chromosome disorders. These are aneuploidy, most commonly due to meiotic non-restriction. So let's search what aneuploidy is. It is the presence of abnormal number of chromosomes in cell, which can lead to various genetic disorders. For example, a human somatic cell typically has 46 chromosomes, but in aneuploidy it may have 45 or 47 chromosomes instead. So it is most commonly due to meiotic non-disruption. Sex chromosome disorders are because of an abnormal number of chromosomes, most commonly due to meiotic non-disruption. The first is Klinefelter syndrome, which is male 47XXY, and the male has small firm testes, infertility, azoospermia, which is the lack of normal sperms, tall stature with eunuchoid proportions. Eunuchoid proportions is delayed epiphyseal closure and increased bone length, and there's also gynecomastia. There's female hair distribution, and it may present the developmental delay, presence of inactivated X chromosome or bar body. Common cause of hypogonadism seen in infertility workup, and there is an increased risk of breast cancer. This genesis of seminal tubules causes decrease in inhibin B, which causes a increase in FSH because inhibin inhibits FSH. So if there's a decrease in inhibin, there is an increase in FSH, and this causes dysgenesis of seminal tubules. And there's also abnormal Leydig cell function, which causes a decrease in testosterone and an increase in luteinizing hormone. Then the next sex chromosome disorder is Turner syndrome, which is in females, and it has a karyotype of 45XO. There is short stature, which is preventable with growth hormone therapy. Ovarian dysgenesis, which is streak ovary. Broad chest with widely spaced nipples. Bicuspid aortic valve. Coarctation of the aorta, in which the femoral pulse is less than the brachial pulse. There are lymphatic defects resulting in webbed neck, which is shown in this picture, or cystic hygroma, which is the lymphedema in feet and hands. There's also horseshoe kidney and high arched pellet, shortened foot metacarpals, most common cause of primary amenorrhea, and there's no bar body. So what is the most common cause of primary amenorrhea? It is Turner syndrome, and there's no bar body as was seen in Klinefelter syndrome. I'd like to see the presentation of Turner syndrome in the picture images. So there are low-set ears, small jawbones, short and wide neck, which is also known as web neck. There are cardiac problems, and there is swollen hands and feet. Problem in the lymph system, which is known as cystic hygroma, lymphedema. There are numerous moles on the body, infertility because of streak ovaries, and there is a wide chest and hyperthyroidism. So again, short stature, which is preventable with growth hormone therapy, streak ovaries, broad chest with widely spaced nipples, bicuspid aortic valve, coarctation of the aorta, which means femoral pulse is greater than brachial pulse. I'd like to search what is coarctation of the aorta. It is a congenital heart defect characterized by a narrowing of the aorta, the main artery that carries oxygen-rich blood from the heart to the rest of the body. So it is basically the narrowing of the aorta. And because of this narrowing, the femoral pulse is less than the brachial pulse. There are lymphatic defects that result in red neck or cystic hygroma. And there's horseshoe kidney, high arched pellet, shortened fourth metacarpals, and most common cause of primary amenorrhea, and there's no bar body. There's menopause before menarche. So there is basically no menses. There's decreased estrogen that leads to increased luteinizing hormone and increased FSH. Sex chromosomes X or rarely Y loss, often due to non-disjunction during meiosis or mitosis, as these disorders are due to meiotic or mitotic non-disjunction. So they say that Turner syndrome can be due to either meiotic or mitotic non-disjunction. Meiosis errors usually occur in paternal gametes, the father, sperm missing the sex chromosome. So, um, they say when there is a disorder of the meiotic non-disjunction, the father is missing the sex chromosome, and mitosis errors occur after zygote formation. So, there, they occur after zygote formation. There is a loss of sex chromosome in some, but not all cells. So there is a mosaic karyotype, example 45X, 46XX, or 45X, 46XY mosaicism associated with increased risk for gonadoblastoma. This is particularly high in the gonadoblastoma. Mhm. And pregnancy is possible in some cases. Uh, Pregnancy is possible with IVF, which is in vitro fertilization, or by giving exogenous estradiol, 17 beta, and progesterone. This point here, 45X or 46 Y and 45X or 46XX mosaicism. So all of these are mosaic karyotypes that are associated with Turner syndrome. It is either you have XO or you have 46XX or you have 45XO or 46XY. And all these karyotypes, both of these karyotypes increase the risk for glioblastoma. Next, sex chromosome disorder is double Y males. It is 47XYY. It is important to differentiate it from Klinefelter syndrome, which was 47 double XY. This one is 41XYY. Phenotypically normal, usually undiagnosed, very tall, normal fertility, may be associated with severe acne, learning disability, autism spectrum disorders. So there is severe acne, learning disability, and autism spectrum disorders, and there's normal fertility, so that's a plus. Other disorders of sex development are formally called intersex states, discrepancy between phenotypic sex, external genitalia influenced by hormonal levels, and gonadal sex, testes versus ovaries corresponds with Y chromosome. All right, so in these intersex states or other disorders of sex development, there is a discrepancy between the phenotypic sex, which is shown by the external genitalia, and these genitalia are influenced by the hormonal levels, and gonadal sex, which is a sex that is determined by the testes versus ovaries, and it corresponds with Y chromosome. So if there's a discrepancy between gonadal sex and phenotypic sex, then these are called intersex state. And the first one is 46 double X DST. Ovaries are present because it is double X, but external genitalia are virilized or atypical. Most commonly due to congenital adrenal hyperplasia, excessive exposure to androgens in early development. So because there is excessive androgens, the external genitalia are virilized, male or atypical, but the ovaries are present. So it is 46XX DST. Then there is 46XY DST, in which testes are present, but external genitalia are feminized or atypical, most commonly due to androgen insensitivity hormone defect in androgen receptor. So one of these has been because of congenital and adrenal hyperplasia, and the other has been caused because of androgen insensitivity syndrome, which is a defect in the androgen receptor. The next is over-testicular DST, in which 46XX is greater than 46XY, and both ovarian and testicular tissues are present. Over-testes and the genitalia are atypical. I'd like to see what a DST is. What is hmm. Disorders of sexual development? Okay, that was given. Disorders of sexual development. If there is an XX, the external genitalia are like the internal gamete forming organs are going to be ovaries, but external genitalia are virilized. And if there's an XY, then the external genitalia are feminized, but the gamete forming organ, that is testes, will be intact as the stereotype. Disorders of sexual development. Diagnosing disorders of sex hormone. So, if there's an increased testosterone and an increased luteinizing hormone, they're saying it is an androgen insensitivity syndrome. So, let's search more about androgen insensitivity syndrome. This is a condition in which a person's body cannot respond to male sex hormones, leading to atypical sexual development in genetically male individuals. So basically, the androgen receptor is impaired. Even though you have appropriate androgen levels, your body cannot respond to it, and uh, thus you have an androgen insensitivity or syndrome, and you have excess of testosterone, and you have excess of luteinizing hormone, but they are not just effective, and this is an androgen insensitivity syndrome. If you have increased levels of testosterone but decreased levels of luteinizing hormone, they're saying it is a testosterone secreting tumor or exogenous androgenic steroids. Um, I'd like to see what is the direction of testosterone with I'd like to use LH. So luteinizing hormone is required in stimulating testosterone production. All right. So basically, when there was an increase in luteinizing hormone, it was increasing testosterone levels. And thus it was androgen insensitivity syndrome because there was increased testosterone and increased luteinizing hormone, but it was just not acting on it. So it caused androgen sensitivity. Now there's a decreased luteinizing hormone, but even though there is a decreased luteinizing hormone production, there is increased testosterone production. So it is testosterone secreting tumor, or you are giving the patient exogenous androgenic steroids. The next is decreased testosterone, even though there is an increased luteinizing hormone production. This is hypergonadotropic or primary hypergonadism. So your gonads are going to be increased in size. What is hypergonadotropic? There's so much new information in this part. Hypergonadotropic is. It is a condition where the gonads fail to respond to gonadotropins, leading to low sex hormone levels and elevated FSH and LH. Okay, so the gonads in hypergonadotropic hypogonadism, the gonads are small, but the gonadotropic hormones are increased in amount because the gonads cannot respond to the gonadotropins. So there is a decreased amount of production of testosterone which are produced by the gonads, but there's increased luteinizing hormone, so it is hypergonadotropic hypergonadism. And similarly, when there are few gonadotropins, but and because of the few gonadotropins, the gonads do not produce the testosterone, there is hypogonadotropic hypogonadism. So when both are decreased, there is hypogonadotropic hypogonadism. When both are increased, there is androgen insensitivity syndrome. When the testosterone is increased, despite a decreased LH, there is testosterone secreting tumor or exogenous androgenic steroids. And when testosterone is decreased, even though there is an excess of LH, then there is hypergonadotropic hypogonadism. Next is diagnosing disorders by physical characteristics. If the patient has a uterus but there are no breasts, then it is a hypergonadotropic hypogonadism in genotypic female and hypergonadotropic or hypogonadotropic hypogonadism in genotypic female. So basically, mm, I'd have to think about this one. Mm. In hypergonadotropic hypogonadism, there is an excess of the hormones, but the gonads are just not able to respond to it. And in hypogonadotropic hypogonadism, there is a decrease in it, and the gonads are not able to respond to it. So there will be no sexual development of the breast in either of these cases. Then there is Mullerian agenesis in genotypic female and androgen insensitivity syndrome in genotypic male. If there is a Mullerian agenesis, there will be development of no uterus, but the breasts are present. And if there is androgen insensitivity syndrome in genotypic male, which is this syndrome, there will be an increase of luteinizing hormone and testosterone. So the uterus will not develop, but the breast will develop. I have to say, why does androgen insensitivity in genotypic male cause? Okay, so because there's an androgen insensitivity, so the person is more likely to develop breast than male sexual characteristics. So there are breasts, but there is no uterus. This means first cause is Mullerian agenesis, and the second cause is androgen insensitivity syndrome in genotypic male. And in any cases where there is a uterus but there are no breasts, then it means that it is hypergonadotropic or hypogonadotropic hypogonadism. Aromatase deficiency is inability to synthesize endogenous estrogens. Okay. It is an autosomal recessive disease. I like to highlight the genetics with yellow. During fetal life, DHEA produced by fetal adrenal glands cannot be converted to estrogen by the placenta and is converted to testosterone peripherally. Virilization of both female infant, atypical genitalia, and mother, acne, hirsutism, fetal androgens can cause placenta. So aromatase is the enzyme that converts androgens to estrogen. During fetal life, they're saying that fetal adrenal glands produce DHEA, which cannot be converted to estrogen by the placenta and is converted to testosterone periphery because there is an aromatase deficiency, and this causes virilization of the female infant with atypical genitalia and the mother. So there is virilization of both the mother and the infant, female infant. This is particularly important to remember that there is both the female infant and the mother are affected in aromatase deficiency. Then is the androgen insensitivity syndrome. There's a defect in androgen receptor resulting in female appearing genetic male 46XY disorder of the sexual development. Was that it? I think so. Breast development and female external genitalia with scant axillary and pubic hair. Rudimentary vagina, uterus and fallopian tubes absent due to persistence of anti-Mullerian hormones from the testes. Patients develop normal functioning testes, often found in labia majora, surgically removed to prevent malignancy. Increased testosterone, estrogen, luteinizing hormone versus sex. Okay, so there's a defect in androgen receptors. And there are the first things first, there is a female appearing genetic male, which was shown in the development of breast, but there was no uterus. So it is genetically a male, but it is female appearing. There is breast development and female external genitalia with scant axillary and pubic hair and a rudimentary vagina. Okay, so only the androgen receptors are defective, and there's nothing going on with the anti-Mullerian hormone. So anti-Mullerian hormone is going to be in effect, and it is going to cause the absence of uterus and fallopian tubes, but there will be rudimentary vagina and female characteristics such as the development of breast and external genitalia. Patients develop normal functioning testes, often found in labia majora. So they, because there's a labia majora, I'm guessing there is a normal functioning testes in it, and is surgically removed to prevent malignancy. And there's increased estrogen, testosterone, and luteinizing hormone versus other chromosome disorders. So in other chromosome disorders, they do not usually have an increase of all these three together, but this one has an increase of testosterone, estrogen, and luteinizing hormone. So there will be a genetically male patient with female appearing characteristics, but no uterus or fallopian tubes. And there would be a functioning testes in the labia majora, which would have to be surgically removed in androgen and centrifugal. Next is 5-alpha reductase deficiency. This is again an autosomal recessive disease. It is sex limited to genetic males. 46XY, again, inability to convert testosterone to dihydrotestosterone. Mm, there is atypical genitalia until puberty when increased testosterone causes masculinization and increased growth of the external genitalia. Testosterone and estrogen levels are normal. Luteinizing hormone is normal or increased, and internal genitalia are normal. So, 5-alpha reductase deficiency is the inability to convert testosterone to dihydrotestosterone, but it gets better in puberty because the testosterone levels cause masculinization or growth of external genitalia, and the hormone levels are normal. Luteinizing hormone is normal, but the internal genitalia are also normal. So everything is particularly normal, but it is sex limited to genetic males, and it gets better when the person reaches puberty. Next is Kalman syndrome. It is failure to complete puberty, a form of hypogonadotropic hypogonadism. So again, hypogonadotropic hypogonadism was a condition in which we had less gonadotropins and thus the gonadic size of the gonads was decreased. And it is a failure to complete puberty. Defective migration of neurons and subsequent failure of olfactory bulbs to develop causes a decreased synthesis of gonadotropin releasing hormone in the hypothalamus. There is hyposmia and anosmia. Okay, so it is basically a disease of the hypothalamus in which there is defective migration of neurons and failure of the olfactory bulbs to develop. When the olfactory bulbs will not develop, they will decrease the synthesis of gonadotropin releasing hormone, and this would cause hyposmia or anosmia because of decreased secretion of, I guess, ADH as well, because the olfactory bulb secretes it. And there's decreased GnRH, FSH, LH, testosterone, and infertility because of low sperm count in males, and amenorrhea in females because there are no hormones that could induce amenorrhea or spermatogenesis. And there is incomplete puberty, and it is a syndrome that is associated with the failure of the development of neurons in the olfactory bulb. Next, we have placental disorders. The first is placental accreta spectrum. Placental accreta spectrum. So it is the abnormal invasion of trophoblastic tissue into the uterine wall. And where is the diagram? Okay, so this is the diagram. This is the myometrium of the uterus. And this is the placenta. And there is abnormal invasion of the trophoblast into the uterine wall. The risk factors are prior C-section or other uterine surgery, areas of uterine scarring, impair normal decidualization. Decidualization. I'm sorry about my pronunciation, but if a patient has had a prior C-section or other uterine surgery, there would be areas where the uterus would be scarred, and this would impair normal decidualization and the invasion of trophoblastic tissue into the uterine wall, which would lead to placenta accreta. Placenta previa is also a risk factor, and placenta previa is basically, if they've shown it here, it is the attachment of placenta over the internal cervical os. Yes, here, attachment of placenta here. This could also be a risk factor for placenta accreta spectrum. Moreover, there is increased maternal age, multiparity. Three types depend on the depth of trophoblastic invasion. So there are three types of placenta accreta. I'd like to search what multiparity is. I'm guessing it is the birth of multiple babies. Yes, more than one, many or more than one at a birth. Okay, so more than one children. Then we have placenta. So the types of placenta accreta are placenta accreta, attaches to myometrium instead of overlying decidua bizalis without invading it, and it is the most common type. All right, so this is the normal placenta. This is the myometrium, and this is the endometrium, and this is the cirrhosis. This is the placenta accreta, in which this is the myometrium, and there's supposedly um, mm, no endometrial lining, and the placenta attaches to directly to the myometrium here. So it is not attaching to the um, mm, it is not having the normal three levels of the uterus, but uh, it is attaching directly to the myometrium without the overlying decidua bizalis, without invading it. There's no invasion of the myometrium here, and it is the most common type. Then there's placenta increta, which partially invades into the myometrium. Increta partially invades into the myometrium. So, okay, so this is the placental lining, and it is directly on the myometrium and placenta accreta, and it is invading the myometrium and placenta increta. And in placenta percreta, it completely invades or perforates through myometrium and serosa, sometimes extending into adjacent organs, example bladder, and this causes hematuria. Right here. Presents with difficulty separating placenta from uterus after fetal delivery and severe postpartum hemorrhage upon attempted manual removal of placenta, often extracted in pieces, and the treatment is hysterectomy, which is the removal of the uterus. So only the removal of uterus can help in this postpartum hemorrhage and the treatment of postpartum hemorrhage after placenta accreta has developed into placenta percreta. Now, placenta previa is the attachment of placenta over internal cervical os. A preview of placenta is visible to cervix. The risk factors are prior C-section and multiparity. It presents with painless vaginal bleeding in third trimester. So there is no pain, but there is vaginal bleeding in the third trimester. Low-lying placenta is located less than 2 centimeters from, but not covering the internal cervical os. It is less than 2 centimeters from the internal cervical os, but it is not completely placenta previa. It is instead called low-lying placenta. Then vasa previa is that fetal vessels run over or less than 2 centimeters from the internal cervical os. The risk factors are filamentous insertion of umbilical cord. Okay, that's a new word for me. Filamentous insertion of umbilical cord. Inserts in chorioamniotic membrane rather than the placenta. So the umbilical cord has a filamentous insertion, which here means that the umbilical cord kind of inserts in the chorioamniotic membrane and not in the placenta. This is the umbilical cord. It is penetrating into the chorioamniotic membrane and not in the placenta, which causes the fetal vessels to travel to placenta unprotected by the Wharton jelly. Okay, so the umbilical cord is not protecting the fetal vessels here, and there is bilobe or succenturiate placenta. So many new terms there are. Bilobe or succenturiate placenta. I haven't heard of succenturiate placenta before. Presents with painless vaginal bleeding, fetal blood from injured vessels upon rupture of membranes accompanied by fetal heart abnormalities. Example, bradycardia may lead to fetal death from exsanguination. Exsanguination. Okay, first of all, I need to check up on my English. So what is a filamentous umbilical cord? Um, Okay, so in a normal pregnancy, the umbilical cord inserts into the center of the placenta and its blood vessels are protected by Wharton's jelly. In filamentous cord insertion, the cord attaches to the membrane surrounding the placenta rather than the placental mass itself. This causes the fetal blood vessels to travel unprotected from the membranes before reaching the placenta, making them vulnerable to compression or rupture during pregnancy. All right, I got that much. Uske baad there is succenturiate placenta. What does that even mean? Succenturiate placenta. with one or more smaller accessory lobes connected to the main placental mass by fetal blood vessels, which can increase risk during pregnancy and delivery. So it is one or more accessory lobes connected to the main placental mass. I'd like to see images of this. So it is a bilobe placenta. There's this part of the placenta, and then there's this part of the placenta. One or more smaller accessory lobes connected to the main placental mass by fetal blood vessels. And what does subcentuariate mean? Accessory or supplementary? They could have just said accessory placenta, but they had to name it subcentuariate placenta. It presents with painless vaginal bleeding, fetal blood from injured blood vessels upon rupture of membranes, accompanied by fetal heart abnormalities, example bradycardia, and may lead to fetal death from exsanguination. What is that? Ex, exsanguination. The actual process of draining or losing blood. All right. Um, Okay. So the fetus can die from losing a lot of blood because there is visa previa and it is associated with a filamentous insertion of the umbilical cord, and the fetal blood vessels are unprotected and they're not covered by the Wharton jelly, or they can be a bilobus centuriate placenta and it presents with painless vaginal bleeding, and the fetus can die from losing a lot of blood or exsanguination. Then there is placental abruption, also called abruptio placenta, and premature separation of placenta from the uterus prior to fetal delivery. The risk factors are maternal hypertension, preeclampsia, um, yes, smoking, cocaine use, abdominal trauma, presents with abrupt, painful vaginal bleeding in third trimester can lead to maternal hypovolemic shock due to hemorrhage and DIC due to release of tissue factor from injured placenta. Fetal distress may be life-threatening for both mother and fetus. So it can cause painful vaginal bleeding in third trimester and can lead to maternal hypovolemic shock and DIC. Maternal hypovolemic shock and DIC are important. It is basically a hypertensive complication because of hypertension in the mother and preeclampsia, smoking and cocaine use and abdominal trauma. The placenta kind of separates from the uterus prior to fetal delivery, and there you can see the separation, and it can lead to painful vaginal bleeding in third trimester and hypovolemic shock in DIC, and it can be life-threatening for both mother and fetus. The next is uterine rupture. Full thickness disruption of uterine wall. Risk factors of prior C-section usually occurs during labor in a subsequent pregnancy and abdominal trauma. Presents with painful vaginal bleeding, fetal heart rate abnormalities, example bradycardia, easily palpable fetal parts, loss of fetal station, maybe life-threatening for both mother and fetus. All right, so what is the fetal station? The fetal station measures how far a baby's head has descended into the mother's pelvis during the labor, ranging from -5 to +5. And there is a loss of fetal station. So there is a loss of the descending of baby into mother's pelvis during labor because of uterine rupture. Postpartum hemorrhage is greater than expected blood loss after delivery, leading causes of maternal mortality worldwide. Etiology are 4 T's: the tone, uterine atony, causes soft, boggy uterus, which is the most common cause of postpartum hemorrhage. Then there is trauma, example, lacerations, incisions, and uterine rupture. Then there is tissue, detained products of conception can cause postpartum hemorrhage, and thrombin, which causes coagulopathy. So the treatment is uterine massage and oxytocin. If there is a refractory postpartum hemorrhage, surgical ligation of uterine or internal iliac arteries is the treatment. Fertility is preserved since ovarian arteries provide colectal circulation. So this is particularly important. If there is refractory postpartum hemorrhage, then There should be surgical ligation of uterine or internal iliac arteries, and it causes no damage to fertility because the ovarian arteries provide collateral circulation to the uterus and the part supplied by internal iliac artery. The four T's of postpartum hemorrhage are tone, trauma, tissue, and thrombin. Ectopic pregnancy is the implantation of fertilized ovum in a site other than the uterus, most often in ampulla or fallopian tube. The risk factor are tubal pathologies, example, scarring from salpingitis. Salpingitis is the inflammation of fallopian tubes. Um, but what is PID? There is always something you know, and then there's always something you want to know. So, mm, pelvic inflammatory disease, right? So the risk factors are tubal pathologies. Tubal pathologies meaning fallopian tube pathologies. Example, scarring from salpingitis, previous ectopic pregnancies, intrauterine device, IVF, presents with first trimester bleeding. Okay, so ectopic pregnancy has been so far the first cause that we've studied that has caused first trimester bleeding and or lower abdominal pain, often clinically mistaken for appendicitis. Suspects in patients with history of amenorrhea, lower than expected rise in HCG based on dates. So the HCG is low. Confirmed with ultrasound, which may show extra ovarian adnexal mass, which is just an ectopic pregnancy, and treatment is methotrexate or surgery. So in normal pregnancy, this is the ovary, these are the fallopian tubes, and this is the uterus, and there's implantation in the uterus. In the ectopic pregnancy, these purplish here are the fimbria. This part is the infundibulum, and this is the ampulla, which is the most common site. This is the isthmus, highest risk of tubal rupture, and this is the interstitium. In any of these parts, there can be an ectopic pregnancy. The most common site is the ampulla, and the site with the highest risk of tubal rupture is the isthmus, and it presents in first trimester bleeding, and it is mistaken for appendicitis, and the suspects in patient with history of amenorrhea, lower than expected rise in HCG based on the dates, and extra ovarian adnexal mass on ultrasound, and the treatment is methotrexate or surgery. So this diagram shows that there's an ectopic pregnancy in the ampulla or the highest portion of the uterus. This point right here. Next is the hydatidiform mole. It is the cystic swelling of chorionic villi and proliferation of chronic epithelium. Only trophoblast presents with vaginal bleeding, MSS, uterine enlargement more than expected, pelvic pressure or pain associated with HCD-mediated sequela. So there is hyperthyroidism, thecal lutein cysts, hyperemesis gravidarum, early preeclampsia, and the treatment is with dilation and cartridge, and sometimes with methotrexate and the monitoring of HCG. Okay, so a hydatidiform mole is basically an abnormal um, conception, and it is the cystic swelling of the chorionic villi and the chorionic epithelium. There's only the trophoblast, and also it is the father's fault because the father's sperm either goes and penetrates an empty ovum, two sperms, or they penetrate an ovum, normal ovum, but there are two sperms, so it causes the development of excess chorionic villi and chorionic epithelium, and there's a lot of trophoblast, and it presents with vaginal bleeding and emesis and uterine enlargement more than expected, and the pelvic pressure of pain. I'd have to search what emesis is. Emesis. Emesis is okay. So there is the vomiting, uterine enlargement more than expected, and it is associated with HCD-mediated sequela. So the symptoms are HCG related because there's a lot of trophoblast, there's a lot of HCG, and there's going to be hyperthyroidism, thecal lutein cysts, hyperemesis, which means a lot of vomiting. Oh no, that a lot of vomiting. Hyperemesis. It is a severe form of nausea and vomiting during pregnancy that can lead to dehydration, weight loss, and electrolyte imbalances. It is a severe form of nausea and vomiting during pregnancy that can lead to dehydration, weight loss, and electrolyte imbalances. And there's early preeclampsia before 20 weeks of gestation. These are all HCD mediated sequelae. And we treated with dilation of the cervix and cottage, which is the removal of scraping of uterine lining, and we treated with methotrexate. The last disease we treated with methotrexate was ectopic pregnancy, and we have to monitor the HCG levels. Um, there are two types of the mole. It could either be a complete mole, which is the most common, and it presents with a karyotype of 46XX or 46XY. It is a normal karyotype because um, the sperm comes and penetrates an ovum that has basically um, mm, most completely commonly enucleated egg. It is an enucleated ovum that has no nucleus, and a single sperm subsequently duplicates paternal DNA. And its histology is that it has hydropic villi, circumferential, and diffuse trophoblastic proliferation. So, this is something interesting. Swollen fluid-filled placental structures that indicate abnormal placental development, often associated with molar pregnancies or other gestational complications. So they are basically swollen villi, these villi. And there is circumferential and diffuse trophoblastic proliferation. There's a lot of trophoblast. There are no fetal parts. The staining for P57 protein is negative. Complete mole is complete male. Okay. So a complete mole is a complete male, and it is paternally imprinted, and there's no P57 protein. I have to search what P57 protein is for. P57 protein. It is a key regulator in development and disease. It contributes to maintaining normal cellular balance by binding and deactivating these enzymes. Um, by inhibiting CDKs, okay, so they inhibit cyclin-dependent kinases, and they apply a brake to cell's progression through its growth and division phases, particularly the G1 phase, and this ensures that a cell only divides when the conditions are appropriate and necessary. So, basically, what does it have to do with pregnancy? So it is basically used for determining the pathologies in pregnancy with the fetal tissue, and the staining is negative, but the staining is positive because partial mole is P57 positive and it is maternally expressed. Um, a better question would be, why is a partial mole P57 positive, but a mole is not? Hmm. Okay, so if P57 is paternally imprinted, that means that the paternal allele is silent. And if it is maternally expressed, it means only the maternal allele produces the P57 protein. Okay, it is a cyclin dependent kinase inhibitor that is paternally imprinted and maternally expressed. So it would not be present in the father, it would be imprinted, and in mothers, it would be expressed because the maternal allele produces P57 protein. As the complete mole is derived entirely from the paternal DNA, it lacks the maternal genome and P57 is absent. Okay, that makes a whole lot of sense. So, because full mole, a complete mole comes from the father does not produce P57, and so the staining for P57 is negative. The uterine size is increased in complete mole and not normal in partial mole. The ACG is increased in complete mole because there would be a whole lot more of trophoblast, I suppose, and in partial mole it is increase but not to the extent of complete mole. The imaging is honeycomb uterus or cluster of grapes or snowstorm on ultrasound. So these are the cluster of grapes, and this is a snowstorm on ultrasound. And the imaging in partial mole would be that of fetal parts. Risk of invasive mole would be 15 to 20% in a complete mole, and in a partial mole, it would be less than 5%. And the risk of choriocarcinoma, which is the carcinoma of the placenta, basically, would be 2% in complete mole and rarely in partial mole. For the karyotype, partial mole will have a karyotype of 69 double triple X, 69 double XY, or 69X double Y. There would be two sperms and one egg. Only some villi are hydropic, and there's minimal focal trophoblastic proliferation. There are fetal parts, unlikely to complete mole, and their P57 is positive because it is maternally expressed. The uterus size is normal. There is a slight increase in HCG. Fetal parts are there on the imaging. There is less than 5% risk of invasive mole, and there is a rare risk of choriocarcinoma. We'll stop this one here and continue in the next part because I fear this is getting too long.